Ladies and gentlemen, welcome to today's webinar hosted by the Supportive Care Coalition and the Catholic Health Association. Today's presentation is titled Bioethics in the Time of Coronavirus, presented by Dr. Daniel Salmasi. Before we get started, I'd like to mention that today's session is being recorded and you are currently in a listen-only mode. You will be receiving an email tomorrow with access to the recording to listen to on demand. We will be having a question and answer session at the end of today's presentation, and you may type in your questions to our speaker at any time using the questions panel on the right side of your screen. If you experience any technical difficulties during today's webinar, you can click the Help tab at the top of your control panel or ask me a question directly in the questions panel. Now, without further delay, it is my pleasure to introduce your moderator for today, Denise Hess, the Executive Director of the Supportive Care Coalition.
Thank you, Brianne, and again, welcome everyone to today's webinar, co-presented by the Catholic Health Association and the Supportive Care Coalition. For those of you learning about the Supportive Care Coalition for the first time, the Coalition is a partnership of Catholic healthcare ministries from across the United States dedicated to advancing excellence in palliative care through ongoing advocacy efforts at the local and national levels, through interprofessional education, through resources in healthcare ethics, and the integration of spirituality in palliative care practice. Coalition members have complimentary access to monthly webinars, numerous resources on our website, and a community of like-minded learners from all disciplines represented in palliative care. And we want to continue to mention during this COVID-19 webinar series that the Coalition has developed and launched a COVID-19 resource page and a caregiver well-being page. Both of these pages are updated on a daily basis, and you can visit those at www.supportivecarecoalition.org to learn more. That is where you can also find the webinar recording from today and from the previous webinars in this series. And since today, we are not only very blessed to welcome Dan Salmasi, but also in the Christian tradition honoring Maundy Thursday, the day when churches around the world remember Jesus's last meal, the Passover meal that he celebrated with his disciples, and that Christian tradition and Christian churches today remember that near the end of the meal, Jesus blessed and shared bread and wine, foreshadowing the gift that Jesus would soon be giving of his own body, his own life, on behalf of all humankind. And how after sharing the bread and the wine with his disciples, Jesus got up from the table and tied a towel around his waist and knelt down and washed each of his disciples' feet, charging them to love one another in the same way he loved them. And if my experience is anything like all of yours, one thing that has been so very striking about the COVID pandemic has not been the hoarding of toilet paper or crowds gathered on the beaches in spite of orders to shelter in place. But what has been most striking to me are the accounts of generosity, of people delivering groceries, sewing surgical masks, holding front porch concerts, looking out for elderly neighbors, and even entire cities cheering healthcare workers from their balconies every night at 7 p.m. In the light of such suffering and loss, as we are seeing now caused by this virus, these acts in this particular week of Holy Week take on an almost sacramental nature, a holy tone of self-giving and self-sacrifice. And so as we begin, I would like to bless all of us gathered on this webinar today with this prayer by Walter Brugemann. God, sink your generosity deep into our lives, that your muchness may expose our false lack. that endlessly receiving, we may endlessly give, so that the world may be made Easter new, without greedy lack, but only wonder. Finish your creation in wonder, love, and praise. Amen. And as I mentioned today, we are especially excited to welcome Dr. Dan Sulmasy. Dan is the Andre Helliger's Professor of Biomedical Ethics in the Departments of Medicine and Philosophy at Georgetown University, where he is acting director of the Kennedy Institute of Ethics and a member of the Pellegrino Center for Clinical Bioethics. His research interests encompass both theoretical and empirical investigations of the ethics of end-of-life decision-making, informed consent for research, and spirituality in medicine. He is the author or editor of 6 books, and he also serves as editor-in-chief of the journal Theoretical Medicine and Bioethics. And so I would now like to welcome and turn it over to you, Dr. Sulmasy. Thank you so much for joining us on this Thursday of Holy Week.
Thank you for that very gracious introduction and for the prayer that you offered, particularly comforting, I think, to all of us at this time. And so I'm thanking the audience as well for coming in and for the work that I'm sure many of you are now doing in the midst of the epidemic. I was asked to talk about bioethical issues, and in light of that, I wanted to give sorry, there's a little delay on the slides, a bit of a background. Here's the outline of what I'm going to do. I want to sort of build this up from the beginning. So I'm going to start with some of the science and the epidemiology and the clinical issues, then go into what I think are the relevant ethical principles and virtues, and the role of casuistry in this before I get into any of the particular issues. I think one of the things that struck me in much of what I've read about bioethics during this pandemic has been that people are giving you answers and telling you this is ethically been approved by the bioethicists, but they're not telling you why. And so I want to build it up from the science and from the medicine and from the ethics to sort of arrive at the proposals that I'm going to give to you today. So we'll start with the disease itself, just to make sure everybody's on the same page. SARS-CoV-2 is the official name of the virus. COVID-19 is the name of the disease, and that's sort of important to distinguish if you hear them out there. The virus is an RNA virus. There are 4 different types. There are alpha and beta strains that are the ones that infect humans, and in fact, up to 1/3 of normal respiratory infections, colds, are caused by different kinds of coronaviruses. But they have recently begun to undergo a series of spontaneous natural mutations which have caused some severe diseases. In 2002, starting also in China, there was a coronavirus that came to be known as SARS, the severe acute respiratory syndrome, that was actually more severe than the SARS-CoV-2, but was actually less infectious, and so didn't spread to as many people and was contained. Similarly, with the MERS virus, the Middle Eastern Respiratory Syndrome, another coronavirus that mutated and was even more fatal, but again less infectious than the one that we are dealing with now. Where did this one come from? The theory is that it came from a live market where live animals are sold, particularly in China, that there was a natural random mutation. Some people had worried this might have been a bioweapons experiment gone wrong, but there's pretty good evidence from scientists that the kind of mutation shows no evidence that it was manipulated but occurred naturally. These coronaviruses start out in bats, and they appear to have infected a creature called a pangolin, a kind of anteater that's very valued among Chinese, both for its meat and the scales for medicine. And then it began not only to infect the pangolins, but the mutation was such that it was able to infect people, and then importantly, spread from one person to another, person-to-person transmission. The symptoms and what you should be watching for and clinicians should be watching for, it really varies from asymptomatic in mostly young people up to very severe disease that can be fatal. Almost everybody has a fever and cough. Some people experience myalgia or fatigue. The most worrisome symptom people feel is shortness of breath. There are some people who have other symptoms, sore throats, a headache, cough, GI symptoms. The incubation period is probably 4, maybe 5 days, but maybe it's somewhere between 2 and 14 days. Again, we're learning as we go along. The mild to moderate disease usually lasts a week. The severe disease, and you saw this actually with Boris Johnson, seems to be that it lasts for about 7 to 10 days, and then maybe somewhere in 7 to 10 days hits more severely. Then if it's really severe, it can progress to the acute respiratory distress syndrome, and many of those patients develop secondary infections, and those are the ones who wind up on the ventilator. Just to give you some comparisons about this, it's about twice as infectious as the flu and much less infectious than measles. The R0 is sort of the average number of people who get infected by a virus by one person who has it, and for the seasonal flu, it's about 1, a little over that. For SARS-CoV-2, it's about 2 people for every 1 infected. Measles is actually much more infectious. 15 people will get it for every 1 infected. There are about 15% of people who get sick enough to be hospitalized. It's more severe in older patients and those with heart failure or diabetes or hypertension. Case fatality rates, again, to sort of give you an idea. The normal seasonal flu, it's about 0.1%, 1 in 1,000 people will die from it. COVID-19 is about 10 times as fatal, and it's about 1% of people who will actually die from it. Maybe, and that's because we're thinking that a lot of people are asymptomatic and may not even know that they have the virus. Some cases, people have thought it might be up to 3%. If you're worried about the next pandemic, you should, because Ebola has a 50% case fatality rate. So we've got to be prepared for other diseases that may come our way. How does it spread? Again, mostly respiratory drops, coughing and sneezing. It can persist on inanimate surfaces like doorknobs and subway straps, but it deteriorates rapidly on those, and even though it can persist, it's usually small numbers of the viral particles, but you can get it, particularly if someone sneezed, wiped their hands on something, and you come by 15 minutes later and pick it up. There is probably also some pre-symptomatic shedding, probably not so efficient again in spreading, although normal speech seems to be able to transmit the virus even in that stage. Asymptomatic infection also can probably spread the virus that way. And then post-symptomatically, shedding does persist in very small amounts for up to 3 weeks from onset. But again, the efficiency of that is low, and most people think that either 7 to 10 or 14 days from the onset, or at least 2 days after your last fever or last symptom, you're probably not going to be terribly infectious to other people. This is Epidemiology 101. The curves that you're seeing are not new. The epidemiologists have seen these for a long time. So here was 1854, a cholera epidemic. You see an onset of cases, a peak, and then a downslope afterwards. Hepatitis A from 2004, an outbreak. You can see the same kind of thing that often happens in nursery schools if people are not vaccinated. We're seeing the same thing. Here in China, you come up to a peak. What seems to be the super peak here is when they actually started testing a lot more people. So the actual curve probably looked a bit more like this before it started sloping down. Again, there are some worries, perhaps about the Chinese still underreporting, but that's the basic shape of the curve. Probably more honestly reported, this is what happened in Korea. There's an uptick in curves, a peak, and then a downslope on the other side. And you'll notice that the tail tends to be a little bit longer and not as steep as the upslope. And that's why people are urging all of you to do your part at home and all of your neighbors to obey shelter in place, social distancing, etc., to try to flatten the curve by avoiding that peak, which is what causes the surge of patients to come into the hospitals and causes most of the kinds of serious ethical questions that many of us are facing. So do your part is what the government says. Now to turn to the ethics, here's the most fundamental message I want to give everybody today, is that the circumstances that we're facing and no circumstances should ever dictate our ethical principles. What we are all about doing is applying our ethical principles to whatever circumstances we encounter. And when the circumstances are extraordinary, as they are in this case, we need our ethical principles more than we ever did before. I'm tired of hearing people saying, this pandemic is changing everything, we have to change our ethics. That's wrong. What we need to do is hold fast to our ethical principles and be smart enough to apply them appropriately to this set of circumstances. Now, many of you, I'm sure, are used to the ordinary way in which we do clinical ethics. The most salient principles in ordinary circumstances are, first, our duty to benefit patients. Everybody who went to medical school told their interviewer that the reason they wanted to do it was to help people. Why do you want to be a doctor, right? So the duty we have is to help our patients. One corollary of that is that we don't want to harm them. One corollary that we ought to pay more attention to in normal circumstances is that we shouldn't do what does not benefit them. We waste a lot of resources. We give sometimes futile care when we shouldn't be doing that. The second principle is our duty to respect patients as persons. And the way we generally do that, the most significant way we do that, is to respect them as moral agents by engaging them in discussions that look to their autonomy. The two principles of benefiting patients and respecting them as persons are the two main ways in which we dictate what we do in normal clinical circumstances. In extraordinary circumstances of overwhelming need and scarce resources, two other principles that are always there come to the foreground under these circumstances. One of those is solidarity and our respect for the common good. And I'm not just talking about the common good the way a utilitarian might, as the sum aggregate of each of our individual goods, but in an integral or holistic sense of the common good, in which the good of each individual is partly constituted by the good of the whole. And there's no better way to explain that than the concept of herd immunity, right? And this is sort of what I use to try to convince patients to get their flu vaccine. It's not actually, I tell the patients, about you, but if enough of us are vaccinated, then everybody benefits, right? So the good of the whole, in part, instantiates what's good for us. And when we all do well, when our nation shines, when our city shines, we share in that as well. And second, the principle of justice. With two aspects to it. One is equity, that we treat patients and all persons as equal on the basis of nothing but their humanity, the fact that they have dignity as being human and nothing else, no matter what their age or the color of their skin or religion. Everybody, as Martin Luther King said, is a somebody, right? The principle of equity. Justice also means fairness, that when we are distributing burdens and benefits, we want to do so in a way that's fair, that's reasonable, that's objective, that's transparent, that's shared by and applicable to all persons in an equal way. Justice is certainly part of bioethics all the time, but in conditions of scarcity and perhaps overwhelming our resources, this becomes more significant. All of those principles are at play in our response to the COVID-19 pandemic, and we need to pay attention to that. The principles are the same even in this pandemic. I don't hear a lot about this, but I think it's an important part of our response to the pandemic to talk about virtue, and particularly the virtues of most of us who are listening in on this, who are healthcare professionals, that we are called to live lives of virtue. After all, we become professionals by having professed, right? Sworn to care for our patients. And this makes demands of us as healthcare professionals that are beyond those that are expected of accountants or shoe salespersons. Right? When I go to the accountant, my taxes might be the issue. When I go to the shoe salesperson, the look of my feet and the comfort of my feet might be the issue. But when I go to the doctor, I am the issue. That has existential significance. And if someone is sick with a virus that they know is lethal and they are short of breath, they are in circumstances in which they have no recourse but to trust us and to trust that we are people of virtue who are there to help them and to help everyone we can to the best of our abilities. What are some of those virtues? Well, there are the classic cardinal virtues, which apply to everybody, but they apply to healthcare professionals in a particular way too. One of those is practical wisdom. We need that in medicine all the time, but we need it more than ever, the Greek word for it, phronesis, in the time of coronavirus. Every medical act is both technical and moral at the same time because we are doing what we're doing for the benefit of our patients. And we need to be wise about the decisions we make and the actions we undertake in a very practical way. What practical wisdom means is we're taking all we know about the science and applying it to individual patients. That's the art of medicine, the practical wisdom of its application. The second cardinal virtue is that of fortitude. There's physical courage involved in caring for patients, particularly in the setting of an infectious disease pandemic. Already at Georgetown, for instance, several of our attendings, 2 of our house officers have become sick in the line of duty with coronavirus. Fortunately, they've gotten over it, but it takes courage to go out there. And we need not only physical courage, but moral courage to do the right thing in the setting of a pandemic. And doing the right thing and being courageous doesn't mean that we take unnecessary risks, right? Courage in an Aristotelian sense is always a mean between being reckless and being pusillanimous, being cowardly, right? We're right in the middle when we do the code, but we're doing it making sure we have all the protective equipment that we need to do it in a way that's safe for us. Temperance. Again, always important in medicine that we don't overtreat our patients, that we're not greedy, that we keep a steady hand. I know in our institution, I'm sure it's the same in yours, that when suddenly there's a rush of patients and there's all this changing of our systems, that we need to be steady with this, to be people who can find the right balance. And justice becomes very significant in this case when we're trying to apportion our resources, whether it's time or ventilators. We want to make sure that we're treating patients fairly. We very much want to be sure we don't waste our resources. There are other virtues that are specific to the healing professions, medicine, nursing, etc. One of those is competence. As my colleague at the University of Chicago, Mark Siegler, says, competence is the first kindness, right? You've got to be competent about what you're doing here. Altruism is a virtue of medical professionals, that we put the good of patients before our own good, at least to a moderate degree. That we're faithful to the trust that patients have in us, that we're compassionate, and Lord knows we need compassion for all those people who are going to be very sick and dying in this setting. We need to be humble. As Tony Fauci, otherwise known to some as the raspy voice of reason, said on television the other night, this virus is humbling us. We don't know everything, and we've got to be humble about what we know in the face of it. And we've got to be people of integrity, that we're basing what we're doing on a solid ethical foundation and doing so with honesty and commitment to our principles. Because the fight against COVID-19 is going to demand great virtue of all of us who are in this. And lastly, I wanted to talk a little about casuistry. Casuistry means case-based reasoning, thinking about precedent cases and what we can learn from them and apply them to our current circumstances. We've been here before. I mean, this is not the first epidemic. It's not the first pandemic. And the lessons that we have learned or should have learned and will learn from COVID-19 are medical, they're political, and they are moral. Historically, for instance, the record of healthcare professionals about the plague in the Middle Ages is pretty sad. Most of the doctors left the city. It was the friars who stayed behind to care for the sick. Yellow fever, I'll talk about that toward the end of the talk. There was an epidemic of yellow fever in Philadelphia at the birth of our nation. And in the contemporary world, we've been here before. We've been through the HIV epidemic. You may have read in America magazine the story of St. Vincent's Hospital being at the center of the AIDS epidemic in New York City, in Greenwich Village. We've experienced SARS, MERS, Ebola. We've got to learn from these, and we have to learn from COVID-19 so we can do better the next time. With all that said, in terms of a background of principles, virtues, and casuistry, here's the advice I want to give all of you. Act as normally as you can, and rely on ethics as your compass. Don't go crazy. Don't think we've got to just start all over and change our ethics. Rely on your ethics as the guide that will get you through. So, here's something about virtue and professionalism in the setting of COVID-19. There is a moral commitment to be competent. Keep up your reading. Learn more. These articles are coming out online first, minute by minute. Attend webinars like this one and other ones. Keep learning. As Hippocrates said, life is short and the art is long. Second, be courageous but practically wise. We do have a commitment to care for the sick, and it's going to take courage to do so, but don't be stupid, right? Use the appropriate precautions, and there's an obligation for institutions to make sure you've got access to those precautions. Be compassionate. Many of us, especially here in the East Coast and maybe down in Los Angeles and certainly in New York City, are seeing lots more suffering and death than we're used to seeing even in our own hospitals. And it's sad to know about, particularly in New York City, trailer trucks that are being used as temporary morgues. That's more death than we're used to seeing in our hospitals. Be compassionate as you can for the people who are suffering from this and who will die from it and for their families. Be temperate. Osler's virtue of equanimitas becomes important here, to keep an even keel in the midst of all of this. Tensions fray when we're under pressure. Try to be as calm as you can, as understanding as you can. Osler said the way you get to equanimity is to recognize in the foibles of the patients and maybe the foibles of your colleagues, foibles not unlike your own, right? Let's be tolerant of each other and try to keep an even keel in this. But to do that, you're going to need resources for yourself, self-care. So it'll mean rest, exercise, family and friends. And what would we have done without Zoom and Skype and WebEx and all these other platforms? And spiritual or religious practices, for many of you, I'm sure, in Catholic healthcare, are important. And for people who are not religious, may have spiritual practices that are helpful to them as well. Now, what are some of the particular kinds of ethical issues that are going to be faced here? Well, one of the first ones, even before we start thinking about the ethics in the setting of a surge, are thinking about public health ethics in general and identifying cases, isolating people, quarantining them. By what right do we do all of those things? Well, these bring us to questions about public health ethics as opposed to the ethics of dealing with clinical patients. I mean, we're balancing individual good versus the common good. All of us have to recognize that for the good of the whole, which ultimately is our good as well, that we need to do certain practices that we're not used to, and we need restrictions on our freedom that we're not used to. However, public health ethics would also dictate a principle of restraint, that we only do as much as is necessary in order to achieve that vital public health goal. We only restrict freedom, we only invade people's privacy to the extent it's necessary in order to achieve the public health goal. So in terms of public health goals, one of the first things we want to do is identify cases, and immediately there were ethical questions that arose there, although nobody sort of thought about them as a form of rationing, they were. So who, if we only have a few tests, do we give them to? When we only had a few tests, we first were just giving them to the patients who were hospitalized. And then we began in our outpatient settings, as we had a few more tests, to give them to people who were symptomatic and we thought had a chance of having the virus, a good chance of having the virus. But we will move, I think, hopefully to a setting where we have enough testing available that we can do population-wide testing, which will make it possible to identify even asymptomatic people who may be part of the perpetuation of the viral epidemic. Secondly, we isolate infected individuals. That's the difference between isolation and quarantine, right? Isolation is when you take someone who is infected and you tell them they can't leave their house. Right? So anybody who's infected, the house officers, for instance, who were infected in the service of patients at our hospital, were sent home and they don't leave the house. And people bring them in food, and they don't go out even to go shopping because they can spread the virus. And we only let them out and they come to the hospital if they get sick enough. That's different from quarantine. Quarantine is when someone has been exposed or we think may have possibly had the virus, that they are told to stay in their houses the same way we would with an infected individual. And how do we find the contacts? Well, one way we do that is the same way we usually do for tuberculosis or other kinds of, or even, let's say, meningitis, other kinds of infectious diseases that are spread by respiratory means. It's by contact tracing. Who have you been around? We'll talk to those people. We sometimes give general announcements. At our institution, people were made aware that there was somebody on the campus helping the students move out from our staff who was sick and got COVID-19. That person disclosed that to the university, and the university made a general announcement to the university community that one of our staff members had become sick. Self-disclosure is another possible means. One Episcopal priest who was the first person in the District of Columbia who became ill and was admitted to our hospital, started tweeting to his parishioners that he had gotten COVID-19 because he had given them communion a few days before, and he thought he had a moral duty to tell them. But that was autonomous and free will, generous gesture on his part. It wasn't mandated by public health authorities of the government. And I think that public naming, which some people have called for, goes a step too far and violates that principle of restraint. Because public naming, let's say, of the individual who was on our campus wouldn't really add very much to the benefit, because all anybody would be told to do would be to be careful about whether you have symptoms or not. And let's say it was a janitor or somebody, people aren't going to necessarily know who it was. But the downside of public naming is that it could discourage positive individuals from reporting, because there's already some shaming of people who are positive. And all of us certainly look nervously at anybody we see on the street who sneezes. So I think that contact tracing, general announcements, and free will self-disclosure are okay, but I'm not okay with public naming. But what about what happens in the event of an overwhelming surge, which is what everybody's worried about? Again, my advice is keep treating COVID-19 patients as you would others. Be practically wise. I think you should ask anyone who's sick enough to be admitted with COVID-19 about their plans should things get worse. But I would avoid COVID-19 alarmism and exceptionalism, and I wouldn't frame advanced care planning conversations in any way that would be thought to be manipulative. So here is the way I would say, if you've got somebody who's admitted to your hospital, here are a few talking points about talking to them about advanced care planning. Again, the principle for doing this is not, oh my gosh, we've got COVID-19. It's respect for patient dignity and agency. Ethics is normal. Ethics as usual. Don't be alarmed, right? We ask everyone who's at increased risk about their wishes for ventilatory support or cardiopulmonary resuscitation. And, most people do fine with COVID-19 and recover. It's only a fraction who need to get on a ventilator, but we hope for the best for you, but we need to plan for the worst. Some people, have already decided that if they were ever to get sick enough for any reason, they wouldn't want to be put on a ventilator, get cardiopulmonary resuscitation, get dialysis. Have you thought about those things, spoken with anyone? Is there anybody we can speak with if you become too sick to talk to us? Do you have a living will or durable power of attorney for health care? One thing that I've seen in some cases that I think shades over toward the manipulative would be to ask them directly, would you consider giving a shot to someone younger or healthier than you? I think that's putting too much pressure on the individual, and particularly at a time when they're sick and vulnerable, making them feel more sick and more vulnerable, potentially unwanted or unvalued. But I think some people will generously say, hey, I'm 87, I've lived a good life, if I need a ventilator and you don't have enough to go around, give it to somebody else. I'd make a note of that, but I wouldn't spontaneously put that on the table for them. And at least for now, in most institutions, and still I think in New York, we are not rationing, and we are doing everything in our power not to ration. I think people need to be reassured about that with all the talk in the newspapers and on television. There is a moral imperative to do everything we can short of rationing. The ethical principle, again, is we do everything reasonable and possible to benefit our patients. So we try to increase the supply, both locally and nationally. The efforts to engage the private sector in increasing the supply of ventilators is important. You can use alternatives that are almost as good, perhaps to temporize if you do run out. Transfer if it's necessary and possible. Perhaps actually having healthcare systems, even Catholic healthcare systems, act as a healthcare system. St. Joe's actually helping St. Mary's. Wouldn't that be wonderful? A real holy family, you know? And maybe be creative. There have been people who've figured out ways to share ventilators, and I know that's been tried at least at Columbia, SUNY Upstate, and Ohio State, where if you have two people of about the same size, it's a little tricky to do, but you might be able, if you're in a desperate situation, share two ventilators by using tubing that has a Y attachment to it. Or, you've seen people using scuba masks in Italy, or people on Long Island. I heard in the news the other day finding ways to do 3D printing to adapt BiPAP machines to make them into ventilators. Anything you can do to help patients short of rationing is good, and we ought to be doing that. But if it becomes necessary, I think that ethical rationing is, again, based on ethics as usual. It's based on need, prognosis, and effectiveness of the treatment. I don't think ethical rationing should be based on individual characteristics not related to need, prognosis, or effectiveness of the treatment. Because to do otherwise would be not to respect the equal dignity of other people. What we ought to be doing is deciding, if we're going to ration, whether the treatment is going to be worthwhile in helping this patient, not whether the person is worth treating. And that's a really important distinction. So for that reason, age alone should not be a criterion. I've seen some people saying, well, nobody over 65 should get a ventilator, or nobody over 70 should get a ventilator. I think there should be no absolute age cutoffs. There might be somebody who's 65, who's otherwise very trim and healthy, and would do better than somebody who's got end-stage cystic fibrosis and is younger. So age alone is not going to tell you whether the treatment is going to be worthwhile. I am also very skeptical about plans that say what we should be doing is maximizing life years or quality-adjusted life years. This is when people's utilitarian versions of the common good come out, rather than the holistic, integral kind of conception of the common good that I was talking about, and I think is the Catholic one. Because if you think about it, maximizing life years is biased against the elderly and the disabled. If you've got two 25-year-olds and one has Down syndrome, and you're maximizing life years, you could say, well, people with Down syndrome, they have a lower life expectancy than other people. That's the reason we're giving it to the other person. It's not about our bias against the disabled. No, I think that's wrong. That shouldn't be the criteria we're using. Yet, age can figure into our estimates of effectiveness, right? So it is true that somebody who's 85 years old probably has less nephrons, a weakened immune system, less stem cells, and we have good data that they're not going to do very well on a ventilator. But that's an estimate of effectiveness. It's not saying that because you are 85, therefore you've all have no right to claim to a ventilator. Disability ought not be a criterion, neither physical nor intellectual. Again, the state of Alabama had criteria that they were touting that have already been struck down as of yesterday, I think, by the Office of Civil Rights of the United States, that said that no one who was retarded would get a ventilator. Again, certain kinds of disabilities might figure into a characterization of their prognosis or their ability to get off the ventilator and be treated effectively. But the fact that someone is old or the fact that someone has cerebral palsy should not be a reason that we are not giving them access to a ventilator. Nor should social worth be a criterion. I've seen this in Spanish guidelines from their the exact words of social worth. We don't want to make this a war of the rich over the poor or the educated over the less educated. We should be basing our decisions for rationing, if we need to do so, on our concern for the common good, not by pitting groups against each other, the wealthy and the healthy and the young versus the poor, disabled, and the old. And we do so by equitably applying rules that would apply to all persons, which are based on need, prognosis, and effectiveness. You may have heard talk about having do not resuscitate orders for everybody. Again, I want to say ethics as usual, no carte blanche exclusion of COVID-19 patients solely on the basis of that diagnosis. You can imagine a 45-year-old with COVID-19 and hypoxemia from pneumonia who might have transient ischemia, and that person might do well with cardiopulmonary resuscitation. Again, you'd need to take proper precautions. A little bit of casuistry. I remember, I've got enough gray hair here, the days when people were talking about automatic DNR orders for people with HIV. Nonetheless, while I don't say we should have blanket rules and say no one with COVID-19 should get CPR, DNR orders may be appropriate, recommended, and consented to by the patient and the surrogate, and we should do things as we normally should. And again, ethics as usual. CPR may be effectively physiologically, or I would say biomedically, futile. If it will not work, or it's going to be repeatedly necessary with the patient dying anyway, two physicians certify it. Under those circumstances, I think you can write a unilateral DNR order. The ethics would be that there's no moral obligation to do what cannot be done. So you can write a DNR order on the basis of patient consent or on the basis of futility, and that should be reasonable, but no carte blanche exclusions of everybody. But be smart when you're doing it. Have, limit the number of people in the room, have enough protective equipment. Ventilator withdrawal, people have talked about that. Again, I think it's ethics as usual. I am personally opposed to unilaterally withdrawing the ventilator from one patient in order to reallocate it to another with a better prognosis, what's sometimes called reallocation. So I think that having started treatment constitutes a commitment to continue treating that patient. If we've triaged them and said, you get the ventilator, we continue to treat that patient unless the patient refuses or it becomes clear that the patient is overwhelmingly unlikely to survive even with treatment. I don't want to have us sort of saying, well, you've got a 60%, you've got a 40% chance, therefore we're going to take the person with the 40% chance off the ventilator and give it to somebody with a 60% chance. It strikes me that starting treatment constitutes a prima facie claim on the part of the patient to continue, and that it starts a relationship. If we start reallocating ventilators the way some people are saying, it turns professionals into dual agents. Could you imagine more distrust from a patient who's already desperately fighting for their life, thinking that you're thinking about the next person who might need to use their ventilator? Again, that said, it's perfectly acceptable to recommend vent withdrawal when chances of success are poor and the patient is suffering, and they can be withdrawn unilaterally if they're effectively futile. That is, the chances of survival are too slim to make it reasonable, and you can just follow your hospital's policies about that. So again, patient consent or futility, there's no reason to continue because there's no benefit, then you can discontinue the ventilator and it becomes available for somebody else. But let's not start pitting patients against each other when they're already in the intensive care unit. There is an ethical mandate always to care. Again, this is ethics as usual. It's imperative to treat the symptoms and address the psychosocial and or spiritual needs of all patients. We should make palliative care referrals, and this is part of a palliative care series. You'll hear more next week. Many of you have heard some in the previous weeks. Palliative care for anybody whose symptoms are refractory and difficult to manage, anyone electing to forego life-sustaining treatment, and certainly anyone who's been triaged to comfort care or the best alternative to a ventilator. And pastoral care needs of these patients need to be addressed. Patients may have spiritual needs, even if they're not physically symptomatic, particularly patients who are isolated from their families for fear of infecting others. And ethics consults will need to be available for difficult cases or questions. I was going to run through a triage protocol, but I think I'll skip over some of the details of that because we'll probably be able to get to that at other cases. But I've given you the basics of the principles that would be involved, and I want to leave some time for questioning because I think that it's important that we say that we want to hope and pray it doesn't come to rationing, that our measures to flatten the curve actually work. And I'm an Italy watcher, and the curve, it got bad in Milan, but it's sloping down even in Italy. It's not spreading to other cities even. Rome is not becoming the second Milan. So hopefully Washington, D.C. won't become the second New York. Los Angeles won't become the second New York. Chicago won't become the second New York. Hopefully. Everybody has to do their part. That's it. Do your part. Flatten the curve. There are lots more ethical issues we could talk about. Special issues in palliative care, preferential access for first responders, more about advanced care planning, organizational ethics, research ethics, surveillance technology. At Georgetown and the Catholic Health Association, we hope by next week we'll be starting a series of 30-minute webinars to try to address these issues for you in more detail. There's a lot of ethics in the COVID-19 pandemic. But I wanted to end by talking about the story of Benjamin Rush, who, as you may know, was a physician, a signer of the Declaration of Independence, who lived in Philadelphia. And in 1793, after the Revolutionary War, after the Constitution in 1789, Philadelphia was hit with this terrible epidemic of yellow fever. And Rush was, like other physicians, urged to leave the city, like the physicians did in the Middle Ages during the plague. And what did Benjamin Rush say? He didn't say, "Oh my, I don't have enough leeches. Damn that George Washington for letting the stockpile deplete during the Revolutionary War. Everything's a mess. Rationing. We ought to ration by life years. After all, we're a young country and we can afford to sacrifice the old and the disabled so that we can continue." Benjamin Rush did not say that. He said, "I have resolved to stick to my principles, my practice, and my patience to the last extremity." And that's the kind of ethics I'm urging for all of you. So happy Passover for those who celebrate Passover. Happy Holy Thursday, and I'm sorry I've only left about 6 minutes for questions, but hopefully we'll have some time for that. Thank you for listening.
Thank you so much, Dr. Somesi. That was jam-packed with so much good information. And we do have just a few minutes for questions. We invite you to navigate to the questions panel and enter your questions there, as dozens of you have already. We can let you know that next week's webinar, part 3 of our series on palliative care and COVID, will get to many of these questions that we won't have time for with Dan today. Unfortunately, Dan will not be with us next week. But while he's here with us, we have several questions, Dr. Somesi, about the slides that you did skip over. If you could talk a little bit about triage decisions and specifically about the using objective scoring system.
Yes. Okay. Let me go back to those, I guess. Then, if I can get it up again. Here we go. Good. No. I don't know how to use this. Well, I think that
yeah, you can go ahead
one
and
of you
start
can
answering, and we'll work on the slides. Yeah, we'll get you back.
Yeah. I think that the use of objective clinical scoring systems is valuable. Again, the first thing should be need. So does the patient need a ventilator, which should be the same as anybody else's decision, right, that you're doing in normal ethics. The second criterion I'm saying is prognosis. So the difference would be if you've got a triage team in place, that instead of calling the MICU to evaluate the patient, you first call the triage team. And the triage team would evaluate. Great, thank you. Maybe I can go back up. Here we go. Good. So there were, so at the level here, you have a triage team. Maybe there are 2 or 3 members, an ethicist, and somebody who knows something about the care of critically ill patients. And part of the reason for that is to separate the treating team from the people who are making these very hard decisions. And the next thing they would look at would be the prognosis of the patient. And I think that people who are have a less than 6-month prognosis, independent of COVID, who now have COVID, are either very unlikely to survive or will not survive very long afterwards, and that such persons could be triaged out, I think, reasonably. Again, it's in the basis of whether this is going to be something that is worthwhile in the short term, not looking at their value as individuals or as or the expected life years we can get from them. And then in terms of effectiveness, it would be patients who have a need and they're not terminally ill. Then you've got to find some way to sort of sort them. And I think scoring would be valuable. We don't have time. I think actually from a medical point of view, Apache 2 would be better than SOFA. A lot of people are using the SOFA score. You might have a criterion like, at least for Apache, anybody over a score of 35, where even outside of COVID, they've got an 85% mortality. You might exclude them, and then the rest would be prioritized, with the lowest score getting the highest priority. These are not on the basis of pre-existing conditions, but they are scoring the acute condition of the patient. So it's about blood pressure, pulse, temperature, bilirubin level, renal function, etc. So I think use of those scoring systems is defensible.
Mm-hmm. Thank you. Thank you. Next, there were several questions about the virtue of justice in light of historic racial inequities in healthcare. Is there ever a case where we might try to correct the imbalance of these historical inequities with regard to access to healthcare in the midst of this pandemic? The question is, should we privilege care or prioritize limited resources to those historically denied?
Yeah. I think it is always a problem to try to solve questions of social justice at the bedside. So I think that it is true that there are pre-existing social inequities in access to care, in access to good care, that also create imbalances in predisposing conditions. And you can look at it locally and you can look at it globally as well. I mean, you have to realize that having a discussion about ventilator priorities and SOFA scores and Apache scores is a privilege for people who live in a world where ventilators are available. If you want to look at real justice on a global sense, there are countries where no one gets on a ventilator except maybe the dictator who's running the country, right? So I think that we shouldn't be trying to reallocate the social ills at the bedside. It's one of the lessons we can learn from this. I don't want somebody who is from a racial minority or who is disabled and already marginalized from that to get privileged access to care. I think it'll be a tough enough sell to get them in this setting equal care. But maybe one of the lessons we learn from this is enough social solidarity that when we're over it, we go back and we try to say, there were some serious problems here about the social inequities that led to more people from minority communities or more disabled people getting ill enough to be on a ventilator, and those need to be corrected, but they're corrected through different means than rationing at the bedside.
Thank you. And if I might impose on our audience and you for just a couple more minutes over the hour, this will be the last question. So this came up in many forms from our participants about holding this tension between being courageous and not reckless, being practically wise in a situation where many of our healthcare providers are facing a lack of personal protective equipment. How might appropriate precautions be taken when PPE might not be as readily available as needed?
Well, again, I think one of the first things to counsel is that if you're in an institution that has already been overusing cardiopulmonary resuscitation, then I would make sure that persons who to a reasonable degree of medical certainty do not have a chance of getting out of the hospital alive, even if they're given cardiopulmonary resuscitation, not have cardiopulmonary resuscitation initiated at all. Because there's no reason to do something that's not going to work and that puts other people in danger. And sometimes we have erred on the side, I think, of doing too much CPR when it really isn't medically indicated. Nonetheless, if it is, then I think you're right that institutions have a duty to provide adequate protection for people who are putting themselves on the line in terms of doing cardiopulmonary resuscitation. And in so doing, that is an obligation for the institution. And if the institution can't get it, then it's an obligation for the system to make sure that people are sharing within the system so that everybody has enough. And if they can't get enough, then it becomes a problem for the government, for the state, for the private sector to make sure that our healthcare workers are protected. But let's say that hasn't happened yet and you're in the situation, then you have to decide, how, in an individual situation, I think balancing out what the patient's need is, what the likelihood is of success is for the person, how inadequate your protection is. Do you have no gowns? Is it the fact that you have a face shield but a regular mask and not an N95 mask? Et cetera. And you'd have to balance that in and make a prudent judgment in those particular circumstances that I can't, write a formula for.
Thank you so much, Dr. Somesi. And in keeping with the spirit of ending on the hour, I would like to thank you again for joining us and taking those questions, and let all those folks know whose questions we didn't get to. As I said, next Thursday at the same time, April 16th, our panel of physicians and ethicists will be returning to continue to discuss the implications of COVID-19 on palliative care and ethical practices. And so we invite you to tune in for that, registration for that webinar, and our April 23rd webinar, where we will hear from experts in the social work and spiritual care field on addressing the challenges of providing care in the context of the pandemic. Registration for that webinar is also open at this time on our website. And so for Dr. Somesi and all of the attendees today, on behalf of the Supportive Care Coalition, we want to thank you. We encourage you to take a few minutes to complete the program evaluation that will come up on your screen as soon as the webinar ends. We value your feedback and we use it to plan future webinars. Thank you, everyone. Have a blessed Holy Week and a lovely day.
Thank you all. Thank you.